Okay, welcome back to part 3 of the chapter 20 on the heart. We just got through talking about the whole cardiac cycle and some of the pressures and the volume that's involved, and hence how can we measure or estimate the efficiency of the heart by its cardiac output now that we know that there exist these stroke volumes and diastolic volumes and end systolic volume. So cardiac output is defined as the amount of blood that is pumped by the left ventricle in 1 minute. And why it's going according to the left ventricle is because it is the left ventricle that actually pumps blood into the systemic circuit. Okay, and that tells you how much oxygen is being delivered to the entire body. So that's why they're going according to the left ventricle. So this is an indication of blood flow through the entire body's peripheral tissue. Now, this value of cardiac output is abbreviated as CO right here in this formula. See, this is what I mean by AMP2 actually requires some memorization of formula and all these different values as well. That's the difficult part of AMP2. Because you have to know how to apply these formulas as well. So cardiac output is affected by two things, okay? One of the things it is affected by is how fast the heart beats, which is the heart rate at which the heart is pumping, okay? And you multiply that by how much blood actually gets pumped out of the ventricle during contraction, which is defined as stroke volume, or SV, as we have defined earlier within the cardiac cycle. So to calculate cardiac output, we can multiply heart rate with stroke volume. For example, if the heart rate is 75 beats per minute, okay, most average people's heart rate, and then the stroke volume is measured to be 80 mils per beat, which was that average stroke volume we talked about. So then the cardiac output would be then 75 times 80, which is equivalent to 6,000 mils per minute, or if we round that down to liters per minute, it will be equivalent to 6 liters per minute. So imagine just 1 minute go by and your heart has already pumped 6 liters worth of blood throughout your entire body. You can see why the cardiac output is so critical. And even if you're slowing down your heart rate by a little bit, that can lead to a very detrimental effect to how much blood you're going to get across to your systemic circuit. Okay, because if you look at the formula here, CO is equal to heart rate times SV. If heart rate goes down, your cardiac output will go down. Or if your stroke volume go down, your cardiac output would also go down. Okay, which is what I mean by knowing how to use this formula to figure out what factors can affect cardiac output. Okay. All right, and in let's say you need to increase cardiac output for whatever reason it is, then you need to either increase heart rate or increase your stroke volume. All right, so let me erase that. Okay, so and the two values that we can use to determine stroke volume is the two that we've talked about, EDV and ESV. Okay, now I'm going to explain again what these values mean. So imagine your pump, your heart being like a little water pump. You play with those water guns where you pull upwards and water gets sucked into the water gun, kind of like that. Okay, so you pull up on the water gun as much as you can and suck in as much of that fluid as you can, and then until you reach that maximum point, you can't pull that plunger any longer. Then this maximum volume of water that you just sucked into your water gun is the same as what we call EDV, end diastolic volume. It is the end of your relaxation phase, which is the maximum amount of fluid that you can contain within that area. In the heart's case, is the ventricles, okay? And then when the heart is pushing or ventricular systole happens, your ventricles will push inwards which will then causes blood to flow into your aorta or the pulmonary trunk, or in your water gun's case, okay, you're going to splash someone with your water in the water gun, okay, from the water gun. So when you push on that plunger on your water gun, you're going to eject all that fluid out, okay, onto the grass, onto the wall, whatever it is. And then somehow, usually with a normal water pump or a water gun, you can never remove entirely 100% of that water you sucked in. So usually you end up with a little bit left over within the plunger itself or within the water gun itself. So whatever is left over, okay, we call that ESV, or end systolic volume, which means it's the end of your contraction phase. You just push down on that plunger to eject as much as water as you can, but there's that left over that you can't get out, okay? So that's the ESV, representing how much blood is left over after your ventricles have finished contracting. And whatever you pushed out, okay, if it's a water gun case, however water came out of your water gun, that is referred as the stroke volume, okay? How much water did you push out of your water gun? Or in the heart's case, how much blood did you push from your ventricles into your great vessels, okay? And then you continue the cycle all over again by sucking in water again into that EDV volume, and then pushing down on the plunger, ejecting the SV volume, and then there's some ESV left over, etc. So this allows us to calculate SV according to EDV and ESV, okay? Which is why how much we can maximally suck into our water gun, in a sense, affect how much we can push out, okay? Kind of like my son, who is not very strong, he has a hard time pulling that plunger all the way out. So he kind of goes halfway and then he has to stop, okay? So that EDV volume is a lot smaller than what I can pull on that water gun, okay? All the way EDV. So my SV is going to be very large, okay? Because I'm able to pull up a lot more water. Whereas for my son, who is only 5-year-old, he can only pull up 50% of that water gun. So the maximum, the SV from him would be a lot lower. Okay. So this is why EDV and ESV has a direct relationship in terms of how much blood we can push out. Okay. So we can calculate SV by taking EDV and subtracting ESV from it. Okay. How much maximal amount of fluid we're able to get and how much is left over is equivalent to how much we have pushed out, okay? Whether it be water from our water gun or blood coming out of your ventricles, okay? Okay, now that we talked about the remember we talked about the dual innervation of the autonomic nervous system at the end of last semester. We talked about how the heart is controlled by sympathetic and parasympathetic of the autonomic nervous system, the lungs, the digestive system, all that stuff we talked about. So this is here where each chapter we're going to bring back a little bit of that autonomic nervous system we talked about. That's why we ended the semester with that particular chapter, because it's the perfect transition into AMP2, which talks a lot about autonomic nervous system's intervention into a lot of these organ systems that we're talking about. So here's one application of the autonomic nervous system for the heart. Remember, we talked about there's different plexus of the autonomic nervous system. The cardiac plexus specifically is the network of nerves that innervate the heart using sympathetic and parasympathetic division of the autonomic nervous system. The cardio acceleratory center within the medulla oblongata will control sympathetic neurons that can increase heart rate. So this is kind of easy to remember. Acceleratory, cardio, okay? That means it accelerates the heart, okay? Which means it will activate, which means it must be, innervated by those sympathetic neurons, because remember, sympathetic is your fight or flight, parasympathetic is your rest and digest. Okay, so if you need things to speed up, become faster, especially in terms of blood pressure, just imagine you trying to run away from an angry dog. Okay, so that's your sympathetic system kicking in, and that's what's going to cause your cardioauxiliary center to accelerate your heart rate. And then cardio inhibitory center within the medulla oblongata then controls parasympathetic neurons that will slow down heart rate. This is you in your nice and rest and digest mode on your couch taking a nap. Okay, so that's when your heart rate can go down, as started by your cardio inhibitory center within the brain. So this is when the brain has an intervention part of your heart rate. Okay, your heart rate is set by your pacemaker cells, but the brain can intervene whenever there is a necessary means to. And I'll talk about when that's the case. Okay. Here comes those baroreceptors and chemoreceptors we talked about last semester as the last chapter. Okay. So baroreceptors, if you remember, are those that measures pressure. Okay, and if we're applying to our cardiovascular system, we're looking at specifically your blood pressure. Chemoreceptor will report levels of dissolved oxygen and carbon dioxide. Okay, remember, chemoreceptors are those that detects levels of chemicals within the blood. Okay, so in this case, in application to the cardiovascular system, is your oxygen level and carbon dioxide level. So these receptor cells will be involved with the homeostatic regulation of heart rate, pressure, and also pH. Okay, and that's why we'll come back. This will be a recurring theme throughout the entire semester, especially when we talk about respiratory system as well. Okay, so both baroreceptors and chemoreceptors are innervated by the two cranial nerves we talked about last semester, your glossopharyngeal nerve and your vagus nerve, for sending the information towards your brain. Okay, for example, something's going wrong with the body, you're bleeding somewhere, blood pressure is dropping crazy, so that signals your baroreceptors is able to detect that, and they say something's wrong, our blood pressure is dropping. So baroreceptors go through the cranial nerves, tells your brain, hey, something's wrong with the body, you gotta intervene now. Pacemaker cells don't intervene with this stuff. So the brain will then send out via the autonomic innervation, via that cardioauxiliary center, will then activate sympathetic neurons to increase your heart rate by releasing the correct neurotransmitter towards that portion. Okay, so that's when your brain need to intervene, is when your homeostatic regulation goes out of whack. Okay, something will happen to change your levels, whether it be chemically speaking in terms of oxygen level, or pressure speaking in terms of blood pressure. So what do I mean by that stuff? So for example, if there was a decrease in blood pressure, like I was saying, in case when you're bleeding, or if there was decline in oxygen, let's say, you had a pneumothorax, someone stabbed you in the lungs area, and now your oxygen levels is rapidly decreasing, okay? Or there will be an increase in carbon dioxide level, especially in the case if you're thinking about drowning, okay? When you're drowning in the pool of water, okay, you cannot breathe. So all that carbon dioxide is stuck in the lungs. So what happens is your body tries to bring your levels back to homeostasis. So all of these cases, whether there's a decline in blood pressure, decline in oxygen level, or increase in carbon dioxide level, it means your heart have to work faster to meet the demands of your peripheral tissue. Okay, of course, your respiratory system will do something as well that we'll talk about when we get to the respiratory system. But then the cardiac centers will now call for an increase in cardiac activity to try to bring it back to homeostasis as best as it can. Okay, I know if it's a severely bleeding case, maybe if you continue to bleed, there's no way you're going to bring blood pressure back to normal into homeostasis unless you get help immediately at the hospital. But your body is naturally going to try to increase your heart rate, which is why when someone's severely bleeding and you see that they're almost dying, there's that heart rate going and indeed, the heart rate stops, is because the heart rate is trying its best to do what it needs to do to bring your blood pressure back to homeostasis. But of course, if the person does not receive help as soon as possible, it drains blood completely out of it. No matter how much your heart pumps, you're not going to get that oxygen, you're not going to get that blood flow. Okay. All right. So both parasympathetic and sympathetic autonomic divisions are actively controlling your cardiac activities, which was what I was talking about last semester with dual innervation of the system. Okay, it's not just sympathetic or just parasympathetic. Both nervous system divisions are intervening every now and then to readjust your heart rate according to your body's demand at the moment. Okay. So when parasympathetic activity increases, your heart rate will decline. And when your sympathetic activation happens, or if parasympathetic activity decreases, your heart rate should increase. Okay, so how are they able to do that? Okay, both parasympathetic and sympathetic neurons, how are they able to activate your heart to pump faster or slow down your heart to pump faster? Well, it goes back to neurotransmitter because these are neurons, okay? We talked about those preganglionic neuron and postganglionic neurons and what neurotransmitter they release, whether it be sympathetic or parasympathetic system, okay? If you remember that. So those neurotransmitter now comes into play in homeostatic regulation of the cardiovascular system. So under normal condition, a resting individual's heartbeat is on average 75 beats per minute, and you see that same depolarization, repolarization, pacemaker potential, get it to threshold, and depolarization again. It's all spontaneous according to what the pacemaker is doing. But let's say we need to intervene. Something's going on. We have to either slow it down or speed it up. Okay, so acetylcholine is the neurotransmitter that is released by your parasympathetic neurons, okay? And they will activate chemically gated potassium channel. Remember, when potassium channels are open, it causes hyperpolarization, which means it is harder for the depolarization to occur because it needs a lot more voltage change to get to that threshold. Okay, so hyperpolarization, you're climbing a steeper curve before you get to threshold, which is why when acetylcholine is released and opening potassium of channels, that's why it slows down those spontaneous depolarization from the pacemaker potential. And then your heart rate, in a sense, will decline because your repolarization duration has been extended. On the other hand, if you need to quicken your heart rate, which is sympathetic stimulation, your neurons, okay, sympathetic neurons specifically, will release norepinephrine, which was the neurotransmitter we talked about that those postganglionic neurons will release. And norepinephrine will bind to specifically what's called beta-1 receptors and allow sodium and calcium ion channels to open, leading to influx of huge amounts of positive ions, which then can increase the rate of depolarization and getting to that threshold even faster because now you have influx of multiple ions, positive charge ions at the same time to bring up your membrane potential. So this will then shortens your repolarization period, and also a much more rapid depolarization because now this gap here is even faster. Pacemaker cells will reach that threshold much more quickly and your heart rate ends up increasing. So make sure you remember which neurotransmitter is released when you need to get your heart rate up, which neurotransmitter is released when you need to get your heart rate down, which one has to do with parasympathetic neurons, which one has to do with sympathetic neurons. If you remember from last semester, this will just be a review, okay? All right. So when Now we're going to talk about factors that affect stroke volume. Remember I talked about how cardiac output is directly affected by SV, okay? Because CO is equal to SV times HR. It doesn't matter which way, okay? But is multiplication of stroke volume and heart rate. Heart rate we've already talked about just now, okay? How heart rate can be changed based on your sympathetic or parasympathetic neurons kicking in. What about SV? What factors can affect SV, okay? Well, SV, we said that is equivalent to EDV minus ESV, which means any factors that can affect either EDV or ESV ultimately would affect SV and ultimately affect cardiac output. So we're going to talk about those factors that will affect your EDV and your ESV. So those that will cause changes in the EDV can be listed in these three things. Remember, EDV value is the maximum amount of blood that can go into the ventricles. So filling time is one thing. This was what I was talking about earlier. How, if you don't allow enough time for those heart muscles to relax fully and contract fully, you're not gonna get enough blood back into the heart, okay? Kind of like you with the water gun, okay? With the water gun, you're gonna go in there and kind of suck up that fluid, and you're gonna go all the way up. It takes longer. But if it's an impatient child like my son, he's going like, okay, I'm gonna pull up a little bit and I'm gonna try to shoot, okay? But you didn't allow enough time for the water to get into the water gun. Same thing for the heart. You're not going to allow enough blood to fill your ventricles. When you don't allow enough filling time, that's going to affect the maximum blood that can be within your ventricle, okay? Venous return. Okay, venous return means the amount of blood that's returning to the heart through veins. Okay, so we're going to remember I talked about the whole circulatory system of systemic circuit. Okay, it has to go through the aorta into the arteries of your entire body, then is collected back in your venous circulation. Your veins then will deliver blood back into the inferior and superior vena cava into the right atrium. Okay, so that's what venous return is. How much blood actually gets returned back into the right atrium, because that will determine how much blood will go into the pulmonary circuit. In a sense, how much blood is going to come out of the systemic, come out of the lungs back into the left atrium. So how much blood returns will either increase or decrease your EDV as well. Okay, if somehow maybe there's a blockage somewhere in your thigh or other places within the veins, then that's gonna decrease your venous return. Okay, and because not enough blood is returning back to the heart, that's gonna affect how much maximum volume you can have in your ventricle. The third value is called preload. Okay, preload has to do with the degree of stretching you can have with the ventricular muscle cells during ventricular diastole. Remember how I said, though the ventricle kind of get plumpy, okay, when they are relaxed, okay, here's the left ventricle and here's the right ventricle, and I said they kind of get plumpy and round. Well, sometimes those muscles are not plumpy and round, okay, they can be maybe somehow they have lost their elasticity and now they're just kind of straight like this instead. Okay, so this versus this is going to affect how much blood can flow into the ventricle. Okay, so the ability of that muscle to relax and stretch, allow the blood to flow through, is the value of preload. Okay. And according to the Frank Sterling principle, if the EDV value increases, so will SV, because if this here increase, your SV will also increase. And that's the whole idea. If more goes in, more will be able to come out. Same thing with my water gun idea. The more water you're able to suck in, the more water you can shoot out from the water gun. Okay. And then how about factors that affect ESV? Okay, how much volume of blood gets left over in the ventricle? Okay, and that can be affected by multiple things. One of them is the same as EDV, preload. Okay, how stretchy this muscle is also has to do with how much blood can actually get to be ejected from the ventricles. Okay. Contractility, okay, which means how much force is produced when a contraction happens at a given preload, okay? Let's say you're like this, okay? Well, you can contract quite a bit, okay, and get a lot of blood into your aorta. But if you're like this to begin with, oh, there's only so little bit room you can squeeze in through, okay? So the contractility, how much you can contract, is kind of related to your preload, but contractility has to do with how much you're able to push in order to push blood through your aorta. Okay, and that can be affected by your autonomic nervous system activity, hormones, drugs, abnormal ion concentration. Those can all alter your contractility. Afterload is something that has to do with how much force your ventricles have to produce in order to open those semilunar valves and eject blood into your systemic circuit. The higher the afterload, the less the stroke volume. Okay, so preload and afterload is two different things, okay? Preload is how much fluid you're able to put into here, okay, based on how big your container is, okay? It's kind of like a big water gun versus a small water gun, okay? That's preload. Afterload is how hard you have to push in order for blood to be ejected from that semilunar valve, aortic valve or pulmonary valve, okay? Sometimes, remember I talked about malformation of valves, sometimes those malformation or deformity of the semilunar valves can make it harder to open those valves, okay? Harder to open the door, because they're overlapping or something's happening, that there's a kink in there or something. So it takes more push to push that door open, kind of like you trying to open a door that has a kink in it and you have to like really struggle to open that door. Well, that's what afterload means. How much force you have to put on that door in order to push the door open, okay? So when the door itself or the valve itself is malfunctioning, you're going to have to use more afterload. And if you're having to push harder in order to open the semilunar valve, that's going to cause not as much blood to be released into your stroke volume, okay? So that's why an increase in afterload results in a decrease of your stroke volume, okay? If we go back to the water gun analogy, that would be how hard you need to push on that plunger in order to spit out the water on the other hand, okay, on the other side of the water gun, okay? So sometimes maybe a rock or something got into the front of the water gun, okay? So now you're like pushing and pushing. I was like, well, man, that water is not coming out, or it starts only leaking like drips out from your water gun. Well, because there's a blockage in that area. Same thing with the valves, okay? There's some valve there, something going wrong where you need to push even harder to get the blood through, okay? All right, so here's sort of all that I talked about that affects heart rate, stroke volume, EDV, ESV in more of a chart format, okay? Here's that venous return I was talking about. Here's that filling time. The more venous return, the higher EDV you're going to have, and all of that would affect ultimately your stroke volume, okay? Increase in EDV, the more SV you would have, okay? The longer you allow filling time to have, the more EDV you will end up with, okay? If it's sympathetic stimulation, okay, that's going to increase your heart rate, which then will increase the contractility and decrease the amount of blood that's left over within the heart, decrease ESV, okay? If it's parasympathetic stimulation, which is then slow down your heart, which slows down your contractility, it will increase the amount of blood that's left over within the heart, okay? Or other hormones can also increase your contractility, like glucagon and thyroid hormone as well, which is why when people have hyperthyroidism, that's why their heart rate goes crazy, is because thyroid hormone ultimately also affects your heart rate. And then we'll talk about vasoconstriction and vasodilation later when we get to the blood vessel chapter. But that ultimately also has to do with your effect with your ESV, okay? And this is just another summary chart that goes over that, where it talks about what can affect heart rate, what can affect stroke volume, which, has to do with your EDV, ESV, and what kind of stuff will affect these values here. So, these couple slides on factors are usually another difficult point or concept for students to grasp, comprehend, and apply them, especially when it comes to a question format. That's when students blank out. I always gets the most, student miss the most questions within this area of the heart. Okay, half of the heart chapter is just on this physiology, mechanistic stuff, on factors that can affect cardiac output and stages of cardiac cycle. So make sure you really spend the time on trying to comprehend, understand it, and try to, and then attack those practice questions at the end of the chapter to see if you really understood what you think you understood. Okay. Like I said, I will include another supplementary video on eCampus that will discuss these factors involved, preload, afterload, contractility, all that stuff, because those videos would have very good animation that illustrate what we mean by those factors. Okay, so be sure to not ignore those supplementary videos. It will help you understand the cardiac cycle and the factors that can affect stroke volume and then ultimately your cardiac output. Okay, so the last concept I want to end this chapter with is a quick introduction to heart diseases, which is in the United States. It is still the number one cause of death through in the whole country, and even though actually cancer is actually getting pretty close to the heart disease. Somewhere, I think heart disease is somewhere in the 600,000 cases of death. And then cancer is about 599 or something like that, okay, thousand. But these are numbers according to the CDC website that was collected in 2017 on leading cause of death for the United States. So that's why I want to talk about and end with coronary artery disease, which is the name for what we know as heart disease. So coronary artery disease is defined as where there are areas of either partial or complete blockage of coronary circulation. Okay, we talked about how there's coronary arteries, cardiac vein, all that stuff. Any of that area, or anterior interventricular artery or posterior interventricular artery, those are places that can become blocked if a plaque was to form in that area. And that reduced circulatory supply of blood is what I said referred to as coronary ischemia. And these blockages usually stems from formation of an arteriosclerotic plaque. Okay, and I'll talk about this when we get to the blood vessel chapter again. What forms these arteriosclerotic plaque is where fat deposit starts to accumulate within the wall of the blood vessels and results in narrowing of the passageway for proper blood flow. Okay, it's supposed to be nice and open like this, but if you close it up, blood can only go through that small little space, and hence that is why you can end up with not enough blood flow to a particular part, especially if that completely closes up the entire blood vessel. And one of the first symptoms of coronary artery disease is called angina pectoris. Okay, pectoris. Okay, remember pectoralis major that we talked about from last semester on muscles. So this has to do with something with the chest, and specifically pain spasm of the chest. Okay, that's why it's called angina pectoris. And usually when it's just beginning signs of coronary artery disease, this only happens when you increase your heart workload, okay, where you will experience some harder pressure against your chest, some chest constriction feeling and pain that kind of radiates from the sternal area to your arms, back, and neck. And an actual heart attack, of course, you will experience pain radiating down the left arm, which is part of that referred pain we talked about last semester as well. Okay. And angiography is a high-resolution ultrasound method that allows us to visualize blood flow within the blood vessels to see whether a blockage exists. And specifically, digital subtraction angiography here is what is commonly used as a clinical procedure for detecting coronary blood flow, so that we can see whether there is specific plaques, within the coronary arteries here that's blocking blood flow. Nowadays, there's also CT angiography, MRA as well. MRA stands for magnetic resonance angiography, which has to do with MRI method. So those are also implemented into looking for plaques within the heart. So this shows you how a normal heart flow looks like. Nice and big blood vessel, no blockage. This is what it will show up as if there is any advanced form of coronary artery disease. Not a lot of blood flow, and also there's a lot of blockage here and there throughout the heart. Okay. And myocardial infarction is the medical term for a heart attack where part of the coronary circulation becomes completely blocked and cardiac muscle cells starts to die because of lack of oxygen. Okay, and those area that is affected by receiving enough oxygen is known as areas of infarct. Okay, so myocardial infarction, no oxygen flow. Myocardial, heart muscles. Okay, so no oxygen blood flow of the heart muscles. That's basically what myocardial infarction means. Now, the severity, severity of the disease, or how likely it is to save a patient from a heart attack, can have to do with the location where the blockage happens. Now, if the blockage was closer to the start of coronary artery, for example, up here instead of down here within these tiny blood vessels, having a blockage here, you're going to block blood flow to the rest of the arteries down here. The tiny arteries down here is not going to get blood. These are not going to get blood. Everything gets stocked up here. So when you have blockage near the start of coronary artery, it will lead to more likely of a widespread damage within the heart, and then the heart may completely stop pumping. Okay, and that usually is the case if they don't get help immediately. The chance of them surviving through the heart attack may be very slim. Now, the second case, if blockage is within the smaller arterial branches, somewhere down here or something, or down here, those may actually survive with some complications, because we're talking about blockage here or here, but at least we have some blood flow here, which means these muscle cells is probably still fine, but down here you might have areas of infarct, but at least it's better than the entire spot of the heart, big large areas of the heart not able to pump or function normally. Okay, but they will recover, may include some complications, however. All right. So this is, myocardial infarction. What develops that kind of onset of heart attack is coronary thrombosis, which we're talking about plaques specifically within heart blood vessel or coronary arteries that we're talking about. The pain that is experienced in a heart attack is very much similar to angina pectoris. It's just that it's not only when you're putting workload on the heart. For example, if you're just beginning of coronary artery disease, maybe you feel fine when you're sitting down, laying down, but as soon as you try to climb upstairs a couple levels, your heart starts to hurt, okay, or your chest starts to hurt, or your arm starts to hurt. Okay, but for onset of heart disease, it hurts even when you're lying down, even when you're sitting down, not really exerting any pressure on the heart, but the chest hurts, the arm hurts, all that stuff. Okay. All right. And how we can diagnose a myocardial infarction in a patient it can be done by ECG, okay, or blood tests. And in blood tests, they will look for presence of enzymes that are specific to the heart. For example, cardiac troponin T, cardiac troponin 1, or CKMB, which are a type of creatine phosphokinase. But these are overall enzyme that's supposed to stay within cardiac muscles. But if cardiac muscles are damaged, they start tearing apart and breaking open. They will release their contents into the blood, which we can detect by the blood test to know that some cardiac muscle fiber is breaking down, or cells are breaking down. Kind of like how we talked about, we're able to look for creatine phosphate in skeletal muscle fiber for indication of skeletal muscle fiber damage. Okay. All right, and the treatment options, one half for heart disease, of course, is medications. And a lot of these medications aims to reduce coagulation, which lowers the risk of forming those coronary thrombosis, like aspirin. Drugs that block sympathetic stimulation, like propranolol, okay? And then you have drugs that cause vasodilation, like nitroglycerin. So these are all trying to slow your heart down, calm your heart back down, because your heart cannot afford to work any harder than it is already trying to with the blockage being in there. So you want to reduce the chance of blood clots by stopping the coagulation. You want to stop sympathetic stimulation from happening. Your heart is already not in a great condition, so you don't want it to go into that crazy mode of fight or flight. And then you want to expand your blood vessels so that it lowers the chance, or maybe increase the likelihood of those blood clots or plaques, kind of traveling away to another spot. Okay. All right, and then non-invasive surgery is another treatment option. Atherectomy has to do with where we're going to reduce the plaque size with the catheter that contains certain surgical tools. There's actually a whole bunch of different surgical tools that is available for this atherectomy. Sometimes there are this ball, oval-shaped thing at the end of the catheter, or there are also scoops, I think, or screwdriver-looking things that goes through that area and kind of splits. Overall, they all work by spinning, okay, and then they will drill that area through and get rid of the fat that's been accumulating in that area. If it's more serious case, they may have to do balloon angioplasty, where the tip of the catheter has a balloon and they're going to expand and blow up the balloon, expand that area via the balloon, and actually leave a stent in place, like kind of like a little metal mesh that holds the blood vessel open after removal of the balloon. That way the blood vessel doesn't collapse. Remember I said in the beginning how blood vessel cannot collapse, or else it will be similar to you stepping on the garden hose. Okay, same thing here. So we need to keep the blood vessel open because the blood vessel wall has already been weakened by long-term storage of these plaque and fat material within the walls. So now, because they're weaker, you need to support it, and hence that's why a stent is usually put in. And another good thing about stent is that they're covered with medications on it, where it prevents the second formation of plaque around that area again. Okay. And if all that, is too late, we can't do all that stuff, the last resort is bypass, okay, where we're going to take a graft from another area of the body, either a small artery or peripheral vein is taken and removed, and then it's going to use to as a bypass to bypass certain areas of blockage. If blockage is right here, they can put a vessel right here. They can put a blood vessel right here. And I think even up till now, the most they will want to do is up to 4 bypasses, quadruple bypasses. Any more than that, it can be dangerous, or the success rate of the surgery can decrease. Okay. Now this is the last note of the chapter. I kind of cut this graph in half when I was talking about this first half of the cardiac cycle and second half of the cardiac cycle. In case you want to see the entire chart, I have for you right here the entire chart of the ECG of one cardiac cycle, and the pressure that's experienced by your atrium, ventricle, and your aorta, and also the volume that's happening throughout the entire cardiac cycle. Okay, now feel free to try to draw these yourself, or draw what I drew, with the blood volume and the heart chambers, all that stuff. Then that's when you really understand this whole cardiac cycle. All right, let's go over the practice questions, and we'll be done with this long chapter, okay, long and tough. Okay, which layer of the pericardium is equivalent to the epicardium, the visceral pericardium, like I was saying? Which of the following is true of the cardiac muscle tissue? They have intercalated discs. They're not larger than skeletal muscle. cardiac muscle is striated, and cardiac muscles tends to be just one nuclei. Only a few have one, two or three, but most of them have one nucleus. Why is the left ventricle more muscular than the right ventricle? We talked about this. Because the left ventricle has to have generate sufficient force to push the blood through the systemic circuit. What is the importance of the 100 millisecond delay of the AV node is the fact that we have to have the atria to contract first before the ventricles. How is the eversion of the AV valves and backflow of blood into the atria prevented by these chordae tendineae and the papillary muscles we talked about immensely? Doris was born with malformed pulmonary valve. How will that affect their circulation? You have a malformed pulmonary valve. So where is pulmonary valve? Blood will then flow back into her right ventricle because right ventricle push through into the pulmonary valve, into the pulmonary trunk. So if pulmonary valve is broken, then the blood is going to remain in her right ventricle. During ventricular systole of the cardiac cycle, all of the following would occur except pressure in the ventricle will force semilunar valves closed. We're talking about ventricle systole, which means contraction of the ventricles. When ventricles contract, semilunar valves open, okay, not close. And the other stuff also happens within ventricle contraction. Rising ventricular blood pressure, which is why that pressure can increase it so you can push open those semilunar valves. Not all for the moment, the all heart valves is closed until they can open the semilunar valves. Atrial diastole would occur as both atria fill. Okay, remember I said the atria diastole kind of last throughout the entire cardiac cycle until you begin the next cardiac cycle again after atrial systole. Okay, so if you are not able to answer these practice questions, that's a good warning sign that you're not understanding the concept from this chapter fully. You should be able to answer these by reasoning your way out. Okay, a lot of these multiple choice questions for AMP2 involves reasoning through. Okay, so make sure you're very familiar with all the different parts of the cardiac cycle. How does damage to the cardioinhibitory center of the medulla affect heart rate? This slows down the heart, so heart rate will increase. Sympathetic will be the dominant nervous system. On an ECG reading, what does P wave indicate? Your atrial depolarization. Ventricular contraction is QRS complex. Okay. And we can never see, not this one. Repolarization, atrial repolarization, we'll never be able to see. What condition contributes to reduction in the size of a T wave? Coronary ischemia that we talked about. What event is taking place during QT interval? It is that single cycle of ventricular depolarization, the QRS complex, and the little bit bump in the back of that, which is the T wave representing the repolarization of the cycle, of the ventricular cycle. What factor could cause an increase in the size of QRS complex of an ECG recording? Increase in heart size is what we talked about. Why is there no wave corresponding to atrial repolarization? Because it is masked by the QRS complex. When during the cardiac cycle do ventricles contain their maximum amount of blood? What is the quantity called? Remember, maximum amount of blood in the ventricles is called EDV, but this happens during the end of atrial systole because this pushes that rest of the 30% into the ventricles, and the end of ventricular diastole is the same thing as that whole ventricle being completely 100% filled with blood. Okay, so B and C are both true. What is the effect of acetylcholine binding to cholinergic receptors? This will decrease the force of cardiac contraction, which decreases heart rate. So this is what I was talking about. You should know which neurotransmitter causes what and what happens to the heart. Okay, there's norepinephrine is the other one, which will then increase heart rate instead. What is the most important factor in considering cardiac function over time? Cardiac output, of course. That's all we talked about in the latter half of the lecture. Frank has just run a marathon. His heart is beating extremely rapidly. What happens to the length of diastole and filling time? Okay, both will decrease, because when your heart rate goes too fast, you don't have enough filling time. Filling time shortens, and the length of those cycles also shortens. How is cardiac output calculated? Right here. Okay, cardiac output is a heart rate multiplied by stroke volume. Okay, and that's all I have for you. And I'll see you back for next chapter, chapter 21.